actually the recommendation now is for a long-acting beta agonist inhaled corticosteroid dual inhaler as actually the first line therapy for even patients as needed.
Welcome. I'm here today with Dr. Andrew Foderaro, who's a pulm critical care doc at Brown University Medicine in Rhode Island. So today the goal is to talk about asthma management. We were talking about this before, but there's so many patients we see in the emergency department or urgent care clinics who have a diagnosis of asthma but don't follow with pulmonology. So thinking it might be good to get an understanding of how we should be managing asthma outpatient, at least getting a rough idea of that. So at least we're discharging these patients on some right inhalers and right medicines.
Yeah, thanks so much for having me. I think this is such an important topic and one that I'm really excited to talk about. For pretty much any of the groups I speak to, I really like to highlight how important I think the understanding of asthma is, because it's really a disease that theoretically should be a reversible disease, right? It's one that hopefully if we deal with the underlying issues, if we treat them well from, whenever this starts, sometimes younger in people's lives, that we can really prevent downstream problems.
Well, maybe we could start by, just walking through what lifestyle recommendations you would give to patients who have asthma.
Often it's a disease of exposures. What we found about asthma is it's not one disease, probably. It's probably a combination of a ton of different possible phenotypes that lead to a similar sort of outcome of people having wheezing and obstruction, these reactive airways. And I think the fact of the matter is sometimes it's really important for people to be involved in thinking through what may be triggers for them. And so I think it's things like environmental exposures, seasonal exposures, also in the house, things like rugs and dust and pets, all of the stuff that you can think of that can cause allergies are really key to understand sort of what could be triggers for people and trying to optimize that in people's lives.
Are there some high yield exposures that you think of? Because there just seems like anything can do it. I mean, maybe it's it's the office a block away from me. Maybe it's my rug, it just seems overwhelming to think about that.
Yeah, I think the things that we often try to target up front, I mean, rugs are a key one for people. They're often not cleaned as much as they should be. And so often the first step we do for patients is trying to have them like actually get to hard floors or remove some of those. Also, honestly, pets are a big exposure for people, and that can be really tough, right? People often pets, they would rather be sick than get rid of their pet.
Put the
But
dog
even just
down.
yeah, but even just like having them in a different room or maybe like not sleeping with them in the bed or something like that can make a big difference for people. And then, I think environmentally, I think outdoor exposures, I think are really important for people. Seasonal allergies actually are extreme contributors. So, I think, for patients, especially if they're going outside or going hiking or things, having the understanding that may be a trigger or trying to avoid certain things at certain seasons. Outside of that, I think, the cleaning and sort of people who do projects with dusts are also really, really high yield, especially construction projects and things like that, really impactful. And the other one that actually I might really highlight is actually that's coming out more recently is actually vape products or other sort of inhaled products, marijuana, things like that can actually be really triggering for asthma, even more so than like cigarette smoking or other tobacco products. And to that point, actually a bigger giant component of this, which is things that we can't necessarily right now do something about, but we're learning much more in the last few years about just air pollution in general and things like global warming.
If so many of these things are sort of allergen exposures, why is there no, first line of taking like a allergy medicine to manage asthma? Like you would think maybe just a Zyrtec or an antihistamine would really help.
And we do actually recommend for a lot of patients to be on one of the allergy, therapies. It sometimes depends on where they're illness is manifesting. So many patients with asthma, they're not every time atopic or allergic, but I think those two things run so closely together that if people do have other symptoms, and these medications are often more effective for, nasal symptoms, eyes, itchiness, more so than the airways. However, I think when I talk with people, if you're having inflammation, you're probably having inflammation more than one place. So I think tackling each of those independently is important. So I almost always, when people have atopic sort of asthma, make sure that they also are on some sort of medication for their allergies.
Now, I think the way most of us think about asthma outpatient is like, okay, we've treated your exacerbation, we've given you some steroids. Now just use your albuterol inhaler, or if it's really bad, use a controller and your albuterol inhaler. But I know there's new guidelines. There's the GINA guidelines, so I don't know what they say. So maybe we can go through, what should patients be taking for asthma?
Yeah, so I think this goes back again, and there's a big shift in the 2019 guidelines from what's been historically noted. And I think everybody who's listening to this probably has seen or ingrained in their this idea of like step up therapy, and like here's all this giant chart of how many times they wake up and all of this stuff. And actually, the move has been to really go away from the idea of asthma severity levels. And it's because um, it's really a misnomer that someone can have mild asthma, because the reality is, and I know you have seen, I see it in the ICU, which is there are the patient that is mild asthma 2 weeks ago who's sitting in my ICU like on a ventilator, right? And so the idea that you can just expect the trajectory to go the same for every patient is not true. And these asthmatics, it's really a sudden reactive change problem, not a chronic change problem. And, I think because of that, the idea of using albuterol, a beta agonist, as the sort of primary first line therapy has really been stressed as maybe not the ideal. And actually, the 2019 and furthering forward, the recommendation has been basically to stop giving people albuterol as the primary therapy. And there's actually two reasons for that. One, it creates this idea that albuterol is the primary therapy, which we know that that's not an anti-inflammation. And so patients get it in their mind that this is the thing they should reach for. And then two, it actually downregulates beta receptors, and it actually makes it less effective if you do get into an exacerbation. For people like yourself in the ER, when people come in and they're really sick, it's actually going to be less effective. And so using albuterol pretty often is maybe not the best. Now, I think having them have one is not unreasonable if they get into a flare or an exacerbation, but really the primary therapy should be a steroid-based inhaler. And actually, the recommendation now is for a long-acting beta agonist inhaled corticosteroid dual inhaler as actually the first-line therapy for even patients as needed. So those quote, intermittent asthmatics that we've known about before who don't get that many symptoms, that actually they would use that as their primary rescue inhaler or as needed inhaler. And that, maybe they would use it, for me, a lot of times if it's, every spring I get a little sick, I would start them on that as a maintenance during that period, and then maybe use it intermittently during other periods of time. Yeah.
What are the main ones that you like to use for those combos?
So I think there are many different kinds. Obviously, you can pull up the charts of all the different inhalers, and most of them have never been shown to be more or less effective. I think for me, there's for instance, Brio is a trade name, and often sometimes why I choose that one is because it's a once a day medication. And actually a lot of the other ones that, people have talked about, things like Advair, Symbicort, which have been around for a long time, or now the generic version of that, Wixela, are twice a day.
So that's just so interesting. So you would generally say anyone with asthma should use that first. And if it's getting to a point where it's chronic enough where you think it's the season where they're going to get it chronically, you might have it be a controller medicine. In other words, just twice a day, no matter what you're feeling.
Correct. Yeah, that's been shown to actually be effective in reducing sort of exacerbations. And actually, the studies that have been coming out have been pretty robust in terms of how much improved sort of asthma outcomes come from using inhaled corticosteroid-based regimens compared to sort of the previous. So I think this is going to be the mainstay. And and I think part of why they made some of the recommendations is they gave two pathways, which is one, you could use the rescue inhaler based inhaled corticosteroid system, or the other is to do an inhaled corticosteroid with an albuterol as well. And they've left that in there mainly because I think there's a lot of patients that just can't, you know, quite fathom how the change is, and they've always used it like this. And so I think that they're sort of transitioning, but I think down the road, that's going to probably be much more of a recommendation to basically not be giving people albuterol, mainly because, again, I think there are some of the negatives of chronic use of albuterol, which really, again, prevents some of the benefit in those acute situations, which we've all seen and can be really some of the more frightening patients if we don't have good ability to open their airways in the acute situation.
But I mean, there still is beta agonism with you have the corticosteroid with the long acting beta agonist. You're still getting beta agonism.
Yeah, it actually doesn't work the same. The short acting actually has a much different effect on how the receptors are. And again, I'm definitely not the expert on the pharmacology of why that happens, but it's definitely not as impactful as using the short acting.
That's amazing. Is there a certain upper limit to, like, you can use these up to this many times per day?
Yeah, generally, we probably would not be going. I mean, most of them are twice a day medications. So generally, it's not quite like the albuterol where you'd be, 3, 4 times a day, at some points if you really need it. Um, you know, Often, if they're having more problems, there can be instances where you can double up on the inhaled corticosteroid, or you may need to add on further meds, or maybe that's when they need, systemic steroids or something else to be helpful. Or if they're really not feeling well, maybe having that albuterol for that sort of flare period might be the right thing. But with strict instructions, like it's not the regular use, it's when people are sort of in a flare or some problem.
So maybe if people are using their inhaled corticosteroid / long acting beta agonist more than 4 times a day or something, that's when it's like, okay, maybe step up to albuterol, but probably get yourself in to get checked out at that point.
Absolutely. And if those happen frequently, then obviously figuring out or targeting why this is happening. And that's honestly why it's so important, I think, for people who, especially if they end up in the emergency room with asthma, to see pulmonologists, which I know is not always the easiest, but there are so many new therapies that are coming out, even therapies that are injection monthly, that are like what we call monoclonal antibody therapies that target these atopic pathways. And I've had so many patients just with remarkable improvement, sometimes coming off inhalers when they get these types of therapies, if they're really pretty significantly impacted.
Are there any other meds that you would think would be important for us to think about from the ED, sort of like first line things that we could try beyond what we just discussed?
Yeah, I mean, I think the things that you highlighted about sort of allergy, especially if they give a history of sort of allergy sort of symptoms, really targeting some of those things would be really important. Things like Singular can actually do both. So it can actually be a somewhat impactful for asthma as well as allergies. But the normal stuff that you think about, whether Allegra, or any of these Claritin, can be actually quite helpful because it decreases sort of across the board inflammation. Some of the things to think about that can be coexistent with asthma. Actually, we find very frequently people with significant reflux disease can actually develop significant asthma, especially if they have reactive airways, because if they get some amount of that acid reflux going in and irritating the airways, that can be a cyclical problem of worsening asthma over and over again. So actually, again, good history. And if they have any of these symptoms, targeting or treating some of those or lifestyle modifications with diet and other stuff can actually make a huge difference for patients. And I think just to highlight again, back with what we talked about originally, probably like 75% of asthma management can be linked back to some environmental or some other comorbid issue that you can make better. So again, a lot of it is really history taking and identifying sort of what may be playing a role in the people's lives.
Cool. Okay. And then, what other recommendations are you going to give to patients?
Yeah, the two things that we often talk a lot about, I think, when we get into these sort of lectures and people have questions about are one, spacers, I think is a great question. And two is actually peak flow meters. You may see those around. There's little boxes that people blow into. Um, I would say the peak flow meters, we often in the pediatric pulmonary world, that's a very, very important component of the regimen. And if you're seeing pediatric asthma patients, because they have a much harder time expressing how they're sort of feeling and knowing. And so being able to track some objective data can be really helpful for parents. In the adult world, I have to say, generally, it can be a little subjective. The idea of the other device that you mentioned, the sort of spacer or some of these other sort of attachments, I think can be really helpful for people. The people that it really helps the most are patients that have a hard time sort of using the inhaler. And using the inhaler, like timing it up, taking a breath. The difficult thing is a lot of these inhalers that are not sort of powder inhalers or the typical sort of delivery mechanism. You see these ones that are like, little discs or some of the other devices. They actually can't really be used with spacers. So it's really important to sort of understand what device type they have. One of the other things that occasionally asthmatics can run into is sometimes they can get a bunch of mucus issues, especially if they're in viral flares. And for some patients, if that becomes an issue, I will occasionally use some of the vibratory devices. So there's the acapella valves is another name for them, but they actually just vibrate when you're breathing in and out. So essentially, the vibrations are transmitted down into the airways because you're breathing through a vibrating sort of device. And
I've
so
never heard
because
of it. Something you put in
yeah,
your mouth or something like that?
yes, you put it into your mouth, you breathe in and out through it, and as you breathe out, essentially it vibrates. And so and then when you breathe in, it vibrates again. And so when you breathe in, all the air that's going in is essentially vibrating, it's oscillating. And so it can disturb that mucus. I usually tell people like 20 minutes after, don't plan on doing things, as you may cough up a bunch of stuff.
Well, great. This is awesome. Yeah, I don't know if there's anything else that you wanted to talk about in this topic.
Yeah, the only other thing I think that gets a little misinterpreted with asthma often is that asthma is really a diagnosis from a clinical perspective. So unless people develop long downstream chronic airway problem due to the inflammation, they won't have abnormal PFTs generally. We don't like to test people when they're in the middle of a flare. So since it's reversible, generally, the most common pulmonary function test is normal. So if you see people and they have PFTs in their system and they're normal, that definitely does not mean that it's not asthma. I typically, I know there's a lot of discussion, about sending people for methacholine testing and things like that, which is actually an airway constrictor, and it's one that occasionally can be used to help support asthma as a diagnosis. I usually don't send people who have pretty clear asthma for that test because I like to use the pulmonary function test to rule out other problems to make sure there's not something else that we're missing on their physiology. But if they have normal testing, they have a clinical history. To me, that's enough to support the diagnosis of asthma. Sometimes you see the bronchodilator response, so we give albuterol in the PFT. That can be another indicator occasionally that people may have asthma because their airways are sort of opening with that beta agonist. The problem is that PFTs really look at bigger airways, and it's really hard to discuss what may be happening at those tiny, tiny airways. And there are people that actually are looking at something called oscillometry, where you test using vibrations to see if the airway are affected by flow.
Interesting. Okay, cool. Very cool. Thank you.
Yeah, absolutely.